Hello, everyone, and welcome to our Whole Person Care webinar series. I am Dr. Holly Lucille. I'm a licensed naturopathic doctor and also senior medical advisor here at FullScript, and I am so glad that you have joined us today once again for one of these. So exciting. So this webinar series is going to be focused on inflammation and cardiovascular health. In today's first session, we're going to be discussing unique inflammation tests that provide additional insight into cardiovascular risk beyond standard lipid testing. Thank goodness, right? We've been doing standard lipid testing just forever. And so super exciting. Okay, next slide. So leading today's session is Dr. Tricia Winchester. She is the Senior Manager of Clinical Education at the Quest Cardiometabolic Center of Excellence at Cleveland Heart Lab. She is a former molecular biology scientist who has spent the past decade in cardiometabolic education, focusing on cardiovascular, metabolic, and common endocrine disorders. She has provided consultation to thousands of providers to help them better understand the clinical tools to identify and monitor at-risk patients and interpret laboratory results. Thank goodness, because still, I think cardiovascular disease is the #1 killer of both men and women. So before we get started, just a few housekeeping notes, and I'm going to repeat these throughout the afternoon. Please submit your questions in the chat, and we will address as many of them as possible after the presentation. And then this webinar is also, of course, being recorded, and the recording will be sent to all the attendees and registrants via email. And you can also access it at fullscript.com/webinar in a couple of days. And there also will be a 5-minute break between each session. So 2 5-minute breaks. And okay, thank you again for joining us, and take it away, Dr. Winchester.
Thank you so much for that introduction. And hi, everybody. Thank you so much for joining today. Disclaimer that I do work for Quest Diagnostics and will be presenting the information today about inflammation. So it's not a surprise that the clinical manifestations are what are seen in clinical practices. And this slide, this slide really encompasses that the clinical manifestations of common cardiometabolic diseases that are the most prevalent in the population, like chronic kidney disease, cardiovascular disease, glycemic control, and fatty liver, are all stemming from shared risk factors. And so this is really the shared risk factor component that we are moving to a more integrated, holistic approach for evaluating patients. It's no longer a silo where if you have blood pressure, you're going to get CKD. If you have lipids, you're going to get cardiovascular disease, right? Because we know that these shared risk factors have a unique interplay between each other, which can then manifest in these clinical manifestations of end-stage disease. And so this is really where Quest had developed the cardiometabolic approach. And really this, again, is nothing new here that you should be seeing from the previous slide, but really emphasizes the interrelatedness between these chronic conditions. So we have here included in the cardiometabolic approach of cardiovascular disease, chronic kidney disease, fatty liver, glycemic control, as well as common endocrine disorders that are related to these cardio conditions. As you may well know, the body is a holistic center where everything interacts with each other. And I think this is most important today to start from a high level view because, as Dr. Lucille had mentioned, we've been so focused on lipids as a center of cardiovascular disease risk identification. However, yet it is still the #1 killer. And so there's really a lot that we can do to really evaluate individuals. And so part of this approach is to help to simplify and keep that at the front of mind. So if you look at the right-hand side in the middle of this circle are risk factors. So these are things that a provider should be taking on an intake of a patient when they're in the room with them. These are the questions that they should be asking. And then from there, they're then evaluating which end-stage disease should I be then more thoroughly evaluating. And so those little green arrows that point to each individual condition are not just a one-step shop, right? It's a whole continuum from a healthy individual to a fully diseased end-stage condition. And really what we do is emphasize that there is years and decades where there are these risk factors that maybe deserve a more critical eye in terms of what is normal for that patient before it progresses into a full-blown disease diagnosis or even having to catch it during the management stage. And so uniquely here, again, from a high level perspective, when we think about cardiovascular disease, we're commonly thinking about lipids, but not just about lipids because there's this interplay between all these risk factors. So when we focus on cardiovascular disease, there really is this unique interplay between lipids, metabolic dysfunction, and inflammation. And lipids can be influenced by insulin resistance. Insulin resistance then can feed into inflammation. Lipids by themselves can feed into inflammation. Inflammation can then act on lipids. It really is a holistic approach. So in order to understand someone's cardiovascular risk and to appropriately risk stratify, it really is to look at these three risk factors, as well as the major cardiometabolic approach, because we know all of those are really playing a role here. And so when we think about the progression of the view of cardiovascular disease, the current view is that its patients are healthy and well until all of a sudden they aren't. And unfortunately, that's the majority, that's more than half the cases where patients are experiencing a cardiovascular event without any prior knowledge that they had cardiovascular risk, that they should be more aggressively treated or should have been on medication or any type of therapeutic that could help to mitigate those risk factors. And so the current view, again, you're low risk all of a sudden when you have these decades of this progression of plaque development, vulnerable plaque, endothelial dysfunction, that all of a sudden leads to a vulnerable plaque eruption. So really this plaque eruption or this plaque rupture is the initiating stage for a clot to form, which then results in the ensuing heart attack or stroke. And so it's this whole notion that maybe we need to be doing a deeper dive to understand the biology of that plaque. And really, the biology of that plaque is telling us how active is that plaque. We know from studies from multiple different populations that it's likely that we are developing plaque as we age. Even young soldiers had evidence of plaque in their blood vessels. But the difference between someone who has plaque in their blood vessels and someone who ensues in a heart attack or stroke is commonly that plaque pathology that is a determining event of will that plaque ensue and result in a plaque rupture. So if we take a step back and think about what are the other current tools that are used to identify high-risk patients for cardiovascular disease. So commonly we might be using a coronary calcium score. Calcified plaque is commonly known as stable plaque. However, stable plaque occurs over years and decades of accumulation of lipids. But let's say that this patient comes back and the patient's calcium score is 0. That's a positive, it's a good thing to have, to have a score of 0. However, we do know that even if the calcium score is 0, that there is likely a significant amount of plaque that's there that's non-calcified. Measuring, is that plaque active? Is it going to be contributing to a future event? Thinking about the likelihood of developing an MI down the road. Another tool that we have is a stress test. The stress test puts undue stress on the heart to determine if that patient has likely any blockages. However, about 70% of a blockage or stenosis needs to be required for that stress test to be considered abnormal. However, we know that in studies looking at plaques every 3 months show that the plaques that are 30 to 40% stenosed are those culprit plaques that then grow due to inflammation and essentially rupture that lead to that ensuing myocardial infarction or heart attack. So a lot that we can do in terms of being able to identify that plaque pathology, and there's unique biomarkers, inflammatory biomarkers for vascular inflammation to help risk stratify patients. So here we have an artery wall, and you can see on the left-hand side here, this is a healthy wall. This is where we want it to be, where there's no plaque, a very small endothelium, which is that one cell layer thick lining that lines all the blood vessels. And then we can see that on the bottom here, we can see that a little bit of crowded intima media thickness starting to ensue, as well as eventually developing foam cell formation. And then that foam cell formation can then grow, and then we start to have some immune mediators in here. And overall, similar to if you were to have a scratch on your knee when you fall down, same thing happens inside your blood vessels. If you have a scratch or a vulnerable plaque where your immune system senses something, it's going to form a clot. And if that clot then blocks the blood flow to the heart or the brain, ensues a heart attack or stroke. And so we have specific biomarkers that can help to identify where a patient is in this spectrum, to be able to help to risk stratify where they are. And because it's telling us about a specific biology, it can help us lend eyes to treatments to how to mitigate that biology from occurring. So from a clinical perspective, inflammation we know can contribute and can be identified along this spectrum, but how about mitigating it? And so in the CANTOS study, looked at high-risk individuals. So these are individuals who had already had a previous and had an elevation of C-reactive protein. And so over time, they used a specific drug called canakinumab, which inhibited the production of hsCRP. And just by inhibiting hsCRP, there was a significant reduction in cardiovascular events, indicating that inflammation is indeed a very important part of the cardiovascular pathway in terms of vulnerable plaques and ensuing events. So now we're going to piece this apart and look at the individual biomarkers that are looked at for vascular inflammation. And so if you think about the left-hand side of the artery wall there, that's really the indication for the risk of disease. And that's where F2 isoproteins and oxidized LDL are going to play a significant role. And both of these biomarkers are markers of oxidative stress, but in different ways. So F2 isoproteins is considered a gold standard for the oxidative stress in the body. It's really produced by the oxidation of arachidonic acid into F2 isoproteins instead of through an enzymatic pathway that produces protein. So really having a high amount of F2 isoproteins can indicate a low-grade inflammation, oxidative stress in the body that can mediate disease initiation and progression. Now, F2 isoproteins is indicated in terms of a lifestyle lie detector test. So obviously lifestyle plays a huge role in the amount of oxidation that is in the body. So if you live a healthy lifestyle, good diet, we would expect F2 isoproteins to be low. LDL is a more specific form of oxidation. And this really happens when the oxidation occurs on the specific protein on lipoprotein particles called apolipoprotein B. So apolipoprotein B is this orange squiggly line that surrounds the lipoprotein. And really ApoB's role is to identify the LDL receptor. Now, when ApoB is oxidized, it actually changes formation. It's no longer able to be recognized by the LDL receptor and actually gets quite sticky and is recognized by scavenger receptors. So when that happens, it makes it more sticky to be into the artery wall. And when this damaged lipid is in the artery wall, it ensues macrophage recruitment to then engulf it, which is essentially the initiating stages for foam cell formation. So when we think about elevations in oxidized LDL, it indicates a risk for developing foam cell formation, as well as actually having a risk for developing metabolic syndrome. And this actually makes sense in terms of poor lifestyle risks, puts us at an increased risk for metabolic syndrome. And oxidized LDL can be an important identifier of that. So really, again, an early risk for disease biomarker that indicates oxidative stress to the lipids. Now, moving on to the presence of disease, we have asymmetric dimethylarginine, which is a biomarker of endothelial dysfunction, as well as C-reactive protein. And these are really in the middle of that artery wall as an indicator of the presence of disease. So asymmetric dimethylarginine and symmetric dimethylarginine are produced from a shared pathway. They have very similar structures, but have different properties. And so again, ADMA is really related to that endothelial health associated with nitric oxide formation, and SDMA with renal function. So let's talk quickly about how they are produced. Cellular proteins are broken down into their basic components like L-arginine, which is then metabolized into nitric oxide. Now, these intracellular proteins are also broken down by methyltransferases into SDMA and ADMA. Now, in a normal healthy individual, ADMA should be further enzymatically degraded, whereas SDMA, because of the switch of the molecule, should be excreted through the kidneys. And so when something goes wrong in this process and allows for ADMA to increase in the bloodstream, it actually competes a lot with the endothelial nitric oxide synthase, which is the enzyme that produces nitric oxide. Now, if you think about the name, asymmetric dimethylarginine looks a lot like L-arginine. And so it competes with free L-arginine, and that way it is actually blocking the production of nitric oxide. So high levels of ADMA have been shown to be associated with more disease burden, and this is through a CIMT measurement. SDMA, because it should be renally excreted, it should be low. However, when the kidneys are not working as great as they should, SDMA can start to increase, and in that way, it actually starts to block the bioavailability of L-arginine to produce nitric oxide. hsCRP. So CRP is an acute phase protein, as we discussed in the CANTOS trial, as a general marker of inflammation. But hsCRP is a more sensitive assessment that's more accurate at lower levels. Because it is a general marker of oxidation, if you're sick or you're injured, your hsCRP is going to come up and then it's going to come back down. But what we're concerned with from cardiovascular disease is really a low, mid-grade, consistent level of inflammation. Why are we concerned with that? A dose-dependent relationship exists between the number of years of sustained hsCRP elevations and an increased risk for CVD and MI. So really, the longer that this exists, the more significant that risk is. The Jupiter trial used specifically medications to lower hsCRP and lipids. And so there was really a benefit for lowering lipids and a benefit for lowering inflammation. CANTOS was the follow-on trial that specifically lowered inflammation, that really put the nail in the coffin that indeed inflammation does play a significant role. in those ensuing cardiovascular events. So moving on into disease activity. So this is that very end stage where we're thinking about that vulnerable plaque, right? The scratch that develops the clot that ensues the heart attack and stroke. So this is really an important stage of looking at plaque vulnerability. And so we'll dive into each of these individually. So Lp-PLA2 activity is really a vascular specific enzyme, and its activity provides information about plaque inflammation and stability. So in our artery wall, it's indicated here by these brown pebbly notions in here, which is actually produced by macrophages. So macrophages go in and they're trying to engulf these lipids. And in that process, they're actually creating a lipid necrotic core. A lipid necrotic core can sometimes be unstable, and that can ensue for instability of that plaque. Overall, Lp-PLA2 activity isn't a great indicator for a risk for future disease, including stroke and CHD. Now, on the flip side of that, we have myeloperoxidase. So myeloperoxidase is also a vascular specific type of inflammation. However, it's from the lumen side of the artery wall. So you can see here that MPO is carried within white blood cells. Now, those white blood cells, those are your army, right? When they are identifying something that doesn't look right, they're going to release myeloperoxidase, which is actually a really strong form of hypochlorous acid that should be getting rid of any invader, right? Getting rid of anything that doesn't belong, doesn't look like self. So in this case, the white blood cells are identifying potentially a vulnerable type of plaque, because if that plaque, that fibrous cap that keeps the plaque in the wall, starts to fissure or degrade, it can actually allow for plaque to seep to the top. Those immune cells identify it and produce some amount of myeloperoxidase. Now, this is identifying an individual who may have a vulnerable type of plaque. So the idea is that when you're identifying elevations in myeloperoxidase, you're identifying a vulnerable type of plaque that you want to mitigate before it results in a plaque rupture later on down the road. So MP is independently associated with incident CHD in a healthy population, and there's a number of studies showing significant correlation with individuals in secondary prevention as well. In a unique study that Quest Diagnostics collaborated with a concierge medicine group called MDVIP, looked at MPO over time. So within a 5-year period, we showed that when providers are informed of myeloperoxidase levels, elevations in MPO did confer a mortality risk, and when they were higher, that incurred even a higher risk to those individuals. But when providers were informed of myeloperoxidase and they were able to identify the risk factor that contributed to it and lower MPO, it actually resulted in a decreased risk for mortality. So very strong in terms of being informed of these biomarkers and being able to mitigate them really conferred a benefit to these patients. Now, MPO acts in combination with other biomarkers. And so really here was another trial showing that hsCRP, MPO are additive when looking at them together. So when we have MPO and CRP both being low, those individuals had the highest survival. When one or the other was elevated, those individuals had a 5.3-fold increased risk. So I guess that arrow should be up, but it's really pointing at that line in the middle. But then if both of those biomarkers, MPO and CRP, were both elevated, those are the individuals who had an additional 4.3-fold increased risk of mortality. So MPO acts with CRP. MPO also acts in combination with Lp-PLA2 activity. And because of this, they're looking at vulnerable plaque from two different sides of the artery wall. We're looking from inside the vessel wall, or a nice analogy is inside the volcano. How much pressure is building up for Lp-PLA2 activity? And then for MPO, it's saying, hey, is there any smoke or is there any lava coming out of the top of the volcano? And in that case, either one of those is going to be an indication that, yes, there is risk factors that contribute to this inflammatory cascade that does put individuals at an increased risk. All right. So that was inflammation in a nutshell. I'll turn it over to Dr. Lucille for any questions. You're on mute still.
I used to have a t-shirt that says you're on mute. All right. Thank you so much. Okay. I do have a couple questions here. So how would someone go about treating inflammatory biomarkers?
Yeah, it's a great question. So inflammation is very similar to looking at the smoke. Like, how is someone individually responding to these risk factors? So you're not just going to treat or wave away the smoke, right? You're going to be looking at what are the risk factors that are contributing to that individualized response to those risk factors. So it's putting a more critical eye on the risk factors that someone has, especially if you aren't expecting, or this person doesn't have any risk factors and you see their inflammation markers elevated. It confers to you a deeper dive into looking at other risk factors that may need to be optimized.
Got you. Okay. So would someone just start with measuring F2 and then go from there?
Yeah, that's another great question. And it's actually a common misconception that it's a domino effect, right? First, you have oxidative stress, and then you go to oxidized LDL and then ADMA. But in reality, when you're evaluating for inflammation markers, it's a snapshot in time. Any one of these can be elevated at any point in time. You're just catching that patient that is identifying that specific biology. It doesn't mean that F2 isoprostanes or oxidized LDL wasn't elevated at some time prior to that. It just means that at this point in time, that biomarker is not at play and it's resulting in a different type of biology.
All right, got it. So the white cells that you talked about that can release the MPO, are those the macrophages?
So the white blood cells are commonly neutrophils that are producing
Mm.
the myeloperoxidase. Macrophage, there's a whole slew of immune cells that are your invaders that are helping to protect the body, which is actually part of inflammation, right? It's your immune system trying to act on these quote unquote invaders, either whether that be oxidized lipids or vulnerable plaque in the bloodstream.
Okay, great. Thank you. So a couple more, if we can get them in. Does reducing these indicators then correlate with reduced mortality for our patients?
Yeah, so that's another great question. And there's a couple of studies that I had discussed in here looking at the Canto study, looking at general inflammation, right? So if you address general inflammation with Kinumab, which isn't indicated as a treatment, but it's for the state of the notion that inflammation does matter and that reducing inflammation does reduce risk. In the case of myeloperoxidase in the mortality study that I had shown, again, when providers were informed of myeloperoxidase and they were able to lower it, it did confer a significant decrease in mortality.
All right. And then, okay, so if someone has high CRP, I know you mentioned that when we're looking at cardiovascular stuff, it's more that mid range. But if CRP is elevated, how do we assess further for cardiovascular disease?
Yeah. So if CRP is elevated and that patient comes back and you have a discussion with them, hey, were you sick at the time of the draw? Were you injured? Something that might help to explain it. But I think really measuring CRP over time, because it really is that dose dependent relationship that confers, yes, if CRP is elevated consistently, that is what confers the cardiovascular risk that that patient might have.
All right, great. Thank you. Okay, thanks, Dr. Winchester, for everything. Thank you all again for attending and participating. Amazing. Okay, if we didn't get to your question and you have a specific one about the report or a test, feel free to contact Quest Product Manager Andrew Hunt. And a quick reminder, these recordings of this session will be sent to all attendees, and then you can also find them in a couple days at fullscript.com/webinar. And now it's time for your 5-minute break before our next session. I encourage you to join us for this second session titled The Role of Specialized Pro-Resolving Mediators in Vascular Health. And this is presented by Melissa Carullo, and it's a fantastic follow-up to what we've learned so far. So we'll see you soon.